Good afternoon. I'm Dr. Usman Tahir, the co-director of the Hypertrophic Cardiomyopathy Clinic and the director for the Center of Cardiovascular Genetics at Beth Israel Deaconess Medical Center. The past few years have been an incredibly exciting time in HCM, and today I will be reviewing the latest updates in the management of hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy results in an unexplained left ventricular hypertrophy of about 15 millimeters or more, or 13 millimeters or more when there's a family history of hypertrophic cardiomyopathy. About half of all individuals who have a genetic mutation in a sarcomere gene, and the other half are non-sarcomeric HCM. Broadly speaking, HCM can be divided into obstructive or non-obstructive HCM. While symptoms may be similar, it's important to understand the mechanism because treatments are quite different. I'd like to focus this update on obstructive hypertrophic cardiomyopathy. Obstructive HCM results from systolic anterior motion of the mitral valve, in addition to the left ventricular hypertrophy that leads to elevated left ventricular outflow tract gradients. To treat hypertrophic cardiomyopathy, beta blockers and calcium channel blockers have been the mainstay of initial therapy. Though there have not been large randomized controlled trials comparing these medications against placebo or to one another, but our clinical experience tells us that these medications are quite effective in treating HCM. And one recent small study did confirm our clinical experience with beta blockers, showing that beta blockers did reduce gradients and improve symptoms, though interestingly, there was a minimal change in terms of exercise capacity. Apart from beta blockers and calcium channel blockers, disopyramide can also be used in HCM, though with side effects, and so caution should be used. If medications do not improve gradients or don't address symptoms, invasive septal reduction therapies, including septalmectomy and alcohol septal ablation, at experienced hypertrophic cardiomyopathy centers can be used. The last several years have been seen incredible advancements in hypertrophic cardiomyopathy medical management. In particular, a new class of medications referred to as myosin inhibitors were developed to target the abnormal mechanics of cardiac muscle contraction. And in fact, were shown to improve compliance and energetics of the myocardium in small animal models. Well, when this drug, now referred to as mavacamten, was studied in clinical trials, mavacamten was shown to improve markers of myocardial stress and injury, reducing levels of BNP and troponin, and most importantly, mavacamten was shown to significantly improve LVOT gradients on top of standard medical care. However, importantly, there was a signal in a subset of patients for a reduction in the left ventricular ejection fraction to below 50%. However, this was reversible with adjustment or stopping medication. With these data in hand, the FDA granted approval to mavacamten for the treatment of symptomatic HCM. However, given the signal of reduced left ventricular ejection fraction in a minority of patients, individuals and providers prescribing the medication need to enroll in a REMS monitoring program where there's a close clinical and imaging follow-up to help adjust medications as necessary based on the LVEF and LVOT gradients. The toolkit for HCM has expanded. Mavacamten is now part of that toolkit in the treatment of HCM. First-line therapy continues to be beta blockers, calcium channel blockers, plus or minus disopyramide, for now, as we learn more about this medication against standard medical care. However, invasive septal reduction therapy continues to be an important option for highly symptomatic patients. Surgical myectomy remains highly effective for the treatment of HCM, and we're fortunate to have Dr. Hassan Rastegar as a surgical director of our HCM program, who has demonstrated that the effectiveness of septal myectomy for individuals with HCM is about 95%, where patients go from NYHA class 3 to 4 down to an NYHA class of 1 to 2. And most importantly, in the right hands, and I can't stress this enough, but in experienced hands, septal myectomy remains a relatively safe procedure with very low mortality rates, less than 1% in high volume operators. The options for HCM management have grown in the recent past, and it really requires a comprehensive assessment to understand individual patient characteristics that may lead to symptom relief. In individuals who do not get adequate relief from beta blockers or calcium channel blocker therapy, we do have the option of offering novel medications and septal reduction therapy highlighted by surgical myectomy, especially individuals who are good surgical candidates. The care of HCM requires experts across the cardiovascular disciplines, including EP, surgery, genetics, imaging, and extensive nurse and pharmacy support. It really takes a village to provide the best and most comprehensive care for hypertrophic cardiomyopathy. And we here at Beth Israel Deaconess Medical Center have an outstanding team dedicated towards the management of HCM. If you would like to refer someone for HCM management, please either email us at hcm@bidmc.harvard.edu or contact us by phone. Thank you.